One of the basic core muscles that supports lower back pain is the transverse abdominis, which runs across the lower abdomen. By feeling the front of your pelvis, there are two hard knobs. By moving in an inch and down an inch on both sides, try to pull your abdomen away from your fingers. Normally, the abdomen should symmetrically move away from both of your fingers slightly. If one side bulges forward out into your finger, it indicates an overactive internal abdominal oblique. The multifidus can be assessed by feeling the bony knobs in your lower back. By going to the bottom of each knob and off to the right and left corners of the bottom of each knob, the multifidus muscle can be felt to contract when the lower abdomen is pulled in towards the spine. If a lack of a bulge exists or a decreased amount of bulge from the right to left sides, that decreased bulging indicates a weak or inhibited multifidus muscle. The function of the glute max or buttock muscle in relation to the lower back muscles can be assessed by using the glute bridge. As you lift your hips from the floor, the tension or hardness of the buttock can be compared to the tension or hardness of the lower back. When feeling the lower back, you want to feel about an inch to the right side or left side of the center of the spine and compare that with your thumb compared to what your fingertips feel on the buttock. Normally, those two tensions should be equal or the buttock should be harder. If the lower back muscle is harder than the buttock, it indicates a weak buttock and a compensatory overworking erector spinae muscle in the lower back. Hip flexion can be used in the face-up position to analyze hip function as well as lower back function. Normally, the arch of the lower back should remain stable when the knee is bent, either one leg at a time or both legs at a time. An increased arching of the lower back indicates poor spinal stability during hip flexion. In the same test, feeling the side of the hip, the greatest bony knob you can find on the side of your hip, will feel like a golf ball. Separating your fingers so you're feeling the front and back sides of that hard protuberance, the hip flexion test when the knee bends can be used to analyze for anterior hip malposition. Normally, that hard bony knob should move backwards or stay exactly where it is when the knee bends. Anterior hip malposition exists when that bony knob moves forward into your front finger and away from your back finger. Tightness of the latissimus muscle, which runs from your shoulder down to your lower back, can be assessed lying face up with your legs straight. Normally, when you reach overhead with one arm at a time or both arms at a time, the lower back should not arch. Use the other hand under your lower back to monitor the curve or arch of your back as you reach overhead. If you cannot touch the floor over your head without increasing the arch of your lower back with either one arm or both arms, it indicates tight latissimus dorsi muscles. Hip rotational alignment can be assessed in the standing position or while walking as well. Normally, the kneecap and the foot both face straight forward while standing and walking, or within a 7-degree toe-out angle. If kneecap and toe turn out more than 7 degrees, either while standing still or while walking, it indicates an external rotation at the hip. If the kneecap faces forward but the toe turns out, it indicates external rotation at the knee. The side of external rotation is usually the same side that is positioned forward with the foot while standing relaxed, or while sitting or lying and crossing the leg at the ankle or the knee. That creates an external hip pattern due to habitual daily habits. External hip rotation and greater on one side causes the whole pelvis to move upwards or hip hike, creating a compression on that side of the lower back. External hip rotation can also be assessed lying face down with the knees bent and the knees together. As the ankles fall out to the side, one side will be freer in its motion and the other side inhibited. That inhibited side, where the ankle can't move out as far, indicates an external hip rotation on that side. A lateral tracking kneecap, where the kneecap moves outwards as opposed to sliding straight up and down, can be assessed in the seated position. Feeling the kneecap on its top inner and outer edges, and while straightening the knee or tensing the thigh muscle, normally the kneecap should exert an equal pressure against both fingers. In a lateral tracking kneecap, the pressure will be greater on the outer finger as the kneecap moves up and away from the inner finger. Diaphragmatic breathing can be assessed in the standing position under normal breathing conditions. Placing one hand on your upper abdomen above your belly button and the other hand on your chest, as you take a normal breath in, normally the abdomen should push out into your hand and not the chest. If the chest moves more than the abdomen, it indicates an accessory chest pattern style of breathing and an incoordinated pattern of using the diaphragm. This can tax the core muscles that are used to stabilize the lower back and add to mechanical back pain.